Great. I would like to invite Dr. Rohan. He's a vitreoretinal surgeon in Chaitanya Eye Hospital. He'll be talking about frugal retinal innovations.
Okay. Good morning, everybody. So I'll be talking about frugal retinal innovations. So first, coming to the Glowport. So trocar cannulas are basically used as they facilitate smooth transfer of instruments and also reduce the trauma. However, room is basically slightly dimmed during PPV, and this can make port visualization difficult. To overcome this, microscope needs to be switched on and off continuously. So the aim was to the aim was to provide a frugal tool providing illumination for instrument exchange in VR surgery without constantly switching on and off the microscope. Sound is not
there. This is compactly fitted over a 25 gauge trocar cannula as shown. The glow device can be pre-fitted and placed over the trocar. After placing the infusion cannula, both the superior cannulas are placed with the glow device on it. The Glowport is then exposed to light from the microscope as well as from the endo illuminator. If you have a green laser filter, you won't be able to capture the phosphorescence in your microscope camera. Under mesopic or dim room light conditions, we visualize the Glowport glowing in the dark. The Glowport, with its property of phosphorescence or glow in the dark, helps us in smooth and efficient instrument exchanges during surgery without having to repeatedly switching on and off the microscope light. The photoluminescence or glow stays for 10 to 15 minutes and it regains its glow after a very brief exposure to the endo illuminator light, as is seen here. Ocular touch errors and effective surgical time is reduced for experienced as well as novice VR surgeons.
So we designed a phosphorescent glow-in-the-dark trocar cannula for smoother instrument exchange, and this was utilized in real-time VR surgeries. So this was a frugal, inexpensive 3D printed novel tool with good source of illumination, with smooth instrument exchanges, reduction in ocular touch errors, and reduction in procedure time, and was beneficial to both the experienced surgeon and the neophytes. Coming to the next one, visualizing the obscure, chromophobe assisted retinal surgery. Basically, in this era of microincision VR surgery with advancement of visualization systems and advanced surgical technique, still 10% of the cases require resurgery. PVR is the most common cause, followed by missed retinal breaks. And even one study said 64% of the cases were due to the missed retinal breaks. So missed breaks are often difficult and can be challenging either due to previous laser scars or due to poor contrast between the choroid or even due to pigmentary changes. So we describe a technique of occult break detection using BBG drug injected into the subretinal space with a 41 gauge cannula and the plume of the dye emanating from the break. So the first patient was underwent a vitrectomy for reg RD 3 months back, presented with dispersed pH and a subtotal RD. After aspiration of the dispersed heme, a break could not be found, so subretinal injection was considered. So BBG was taken in a subretinal injector with reduced PFI pressure and injected subretinally. After displacement with PFCL, you can see the bloom of the dye emitting at 2 o'clock position. So this was then followed by a routine surgery. At 3 months post-op, the retina was attached under oil with 6x60 vision. For the second patient, it is also important to know that there should not be air in the trocar cannula, otherwise they can have an inadvertent subretinal air injection. So after displacing with PFCL, you can see that the plume that I emitting from the occult break, and this was then followed by the routine surgery. At 3 months, retina was attached under oil. The fourth was a case of re-RD. After peeling the PVR membranes, a break could not be, subretinal BBG was injected, but a break could not be seen. So hence a drainage retinotomy was made and the retina was settled under oil. So BBG dye was selected because it was safe, as seen in various studies. There was another technique where they injected transclearly the dye, but it was associated with hypotony, choroidal and retinal hemorrhages, vitreous incarceration and retinal incarceration. So to conclude, subretinal dye injection is useful for occult or missed break detection. It provides a good color contrast. It helps in avoiding a posterior drainage retinotomy. Also helpful in recurrent retinal detachments, and this dye is also non-toxic and safe in Indian eyes. Coming to Lumindent. So in VR surgery, essentially we need 3 hands, one from the surgeon and one from the assistant. So during surgery, we need the assistant to actually depress first. It can result in slippage, sometimes miscommunication, and even an accidental retinotomy. So as a solution, we wanted to combine the depressor and the illuminator into one instrument. So the endoilluminator, it was placed on a hypodermic needle cap and secured with a microscope. And all these material are easily available in your operating theater. The video demonstrates how it is assembled. You can see the transclear illumination with the Lumindent, and this frees up the surgeon's hand for either a base shaving or even lasering under depression. Now, what if you don't have an endoilluminator? You can use an insulin syringe with an LED light source connected to a battery, and all this can be sterilized except for the battery. This can also be attached to a power bank. So companies also provide a similar solution, but they are either proprietary. Urintan did a modified illuminated scleral depressor using a scleral bud, but then the problem is there can be blunting of the scissors. The wet cotton bud also loses form. All this can be easily overcome with the Lumindent. So to conclude, it's a do-it-yourself, easily replicable, made using discarded material. It's sturdy, sterilizable, emits lights diffusely, and can be used without an endoilluminator. So coming to Retilight, during surgery, the most important aspect is visualization. Therefore, without a light source, it's almost impossible to do a surgery. So if the endoilluminator is not working, then what is the solution? So we needed a frugal novel illuminator device in case of emergencies. So the xenon light source is basically condensed onto the endoilluminator light pipe. 2 adapters were made, a retina adapter and a light adapter, to which you can fit the head of the endoilluminator and the LED light source. This can be mixed and matched with depending upon the operating system you utilize in your theater. The video shows how easily the device can be removed. To one end, you insert the endoilluminator head, the other holds a light source. But the problem was the illumination was a little low. So Retilight 2.0 was innovated, where you used a bigger, higher LED light source, but it required a heatsink and a fan. So this was a Retilight 2.0 with connected to a power bank. You can see the good illumination coming from that. Can even be utilized in VR surgery to complete the surgery. It's also useful as a source of retro illumination anterior segment surgeries, and even as a spotlight during orbital surgeries. So it's a frugal, it's universally modifiable, it's ultra portable. It can be used not only by the retinal surgeons but also by the other specialties, and it's a multi-purpose illumination device. Thank you.